Hey everyone, I'm Joe Turner, Dylan Cooper with the Indiana University School of Medicine, Department of Emergency Medicine. We got Chris Eddy here with us from the Department of Anesthesia as well. And we wanted to talk to you about an intubation technique that we'd like to see you use if you're not using it already.
So, as you probably know, for decades, we've traditionally intubated in the supine position, both in the operating room and in the ER, which seems to not make a lot of sense in particular patient populations, especially considering patients who are hypoxemic, who have a lot of redundant tissue, big necks, sleep apnea, and patients who might be at a high aspiration risk.
For the past couple years, we've basically been encouraging our residents to intubate with the head of the bed sort of up, more at like a 45-degree angle. We call this upright intubation. There's a couple other terms that you'll see in the literature, head elevated intubation.
And so what this does is it offers a number of advantages. There have actually been some ICU-based studies that have looked at complications after intubation and have shown favorable results in patients who are in the upright position. But as you can imagine, theoretically there would be some advantages to being able to mask ventilate these patients more effectively, potentially decrease risk of aspiration, and then ultimately ease of intubation is what we've looked at.
Yeah, I think that's the biggest thing for us is just we find it to be easier. We find this actually facilitates successful intubation, increases our chance of first pass success. We find that you get better laryngeal views actually doing it this way, which I think has something to do with sort of the alignment of the axes as well as just decreased force of gravity. If you have a person with a lot of redundant neck tissue, you're not having to pull as hard against the force of gravity.
And so as Joe's demonstrated, we've elevated the head of this bed. There are a number of different techniques which Dylan will show you here in just a second, but typically what we'll try to accomplish is having the head of the patient as close to the head of the bed as possible, maybe moving the patient over to the right side of the bed so that the person who's intubating has the best sort of mechanical advantage to be able to intubate successfully.
And depending on the bed type, you may need a stool back here, or this type of bed, you don't even really need a stool. Dylan's tall enough that he can do it. Sometimes, you know, as I'm the attending and I'm supervising a resident, sometimes I'll just come stand at the, right side of the patient's head right here, and I got my left hand, and I'm sort of already in line with the airway axis, so I can just intubate from this position as well. Dylan will sort of demonstrate how we do this.
Yeah, so basically same skills that you would use in intubating a patient supine. So once they're in this position, we've now got them on our supplemental oxygen, try to hyperoxygenate them as much as we can before we intubate them. And so we're going to go in again, same approach, moving the jaw, going down. Here I have a curved blade, and I'm just looking straight in. I see cords, and I'm passing the tube in. I'm visualizing it go through the cords, same as you would do a supine intubation, it's just in an upright position. The one that Joe mentioned is from the side of the bed, so for example, if Joe was there and I was helping out and he wanted to do the intubation, he could now lean over and actually on the side of the bed, take a look. Again, visualizing cords going straight through with the ET tube.
I think the big things here are, one, just sort of get the bed down as low as you possibly can and get the patient scooted up in the bed too, and that'll sort of help you out. So as you can see, this is a fairly easy technique. It's pretty quick to learn. We just recently published a study in the American Journal of Emergency Medicine looking at our experience over the course of about a year, and we found that our residents actually had higher success intubating in this position than in the traditional supine position. So we think that combined with some of the patient-centered benefits really make this a compelling case that you probably should be intubating in this position.